Hello, I'm Dr. G.A. Prasad from the Division of Gastroenterology and Hepatology at Mayo Clinic. I'm an associate professor and I work in the Barrett's Esophagus unit. I'm here to discuss our paper which is going to be published in the December issue of the Mayo Clinic Proceedings in 2011. This paper is titled Population Screening for Barrett's Esophagus, a prospective randomized pilot study. Barrett's esophagus is the strongest risk factor for esophageal adenocarcinoma and precedes almost all esophageal adenocarcinomas. Unfortunately, only 10% of all esophageal adenocarcinomas diagnosed in the United States are known to have Barrett's preceding the diagnosis. Hence, if these patients are known to have Barrett's before they are diagnosed and can be put into a surveillance program, esophageal cancer can be detected at an earlier stage and hopefully lead to better outcomes than currently. Sedated endoscopy is currently the conventional tool for diagnosing patients with Barrett's esophagus. Unfortunately, sedated endoscopy is an expensive tool, needs sedation, which means that patients and their caregivers have to miss days of work and can also be associated with serious complications. Hence, it may not be the most cost-effective tool for screening patients for Barrett's esophagus. There are some novel unsedated tools, such as unsedated transnasal endoscopy, as well as capsule endoscopy, which may not need sedation, may be less expensive, and therefore may be feasible tools for screening for Barrett's esophagus in the community. Unsedated transnasal endoscopy is conducted by inserting a small, less than 5 millimeter endoscope through the nostril into the esophagus to assess the esophagus and stomach junction and see if there is any evidence of Barrett's esophagus, esophagitis, or esophageal cancer. Capsule endoscopy is conducted by having the patient swallow a capsule which is about the size of a vitamin pill with a camera on either end, and this allows us to examine the lower end of the esophagus and the upper end of the stomach for any reflux related changes. Neither of these techniques require any intravenous sedation, and hence the patient is able to leave right after the procedure and does not lose work or does not require a caregiver to accompany them for the test. Unfortunately, there is currently no information on their acceptability in the population, as well as whether they are indeed safe and feasible. We aim to address these gaps in our knowledge in this study. In our population-based study, we randomly assigned patients drawn from the community to these three screening tools, the three being sedated endoscopy, unsedated transnasal endoscopy, and capsule endoscopy. Patients were recruited from Olmsted County, from a universe of subjects who had responded to a GI symptom questionnaire which had been mailed out a couple years ago prior to this study. Hence, we were able to stratify patients by age, gender, as well as reflux symptoms. Patients were pre-randomized to the three tools for screening and offered screening with a telephone call. The primary aim of our study was to assess what proportion of patients accepted screening with these three techniques when offered. We also assessed the safety characteristics of these three techniques and the yield of these three techniques. This was a small pilot study where we aimed to recruit 20 patients in each of the three arms. Overall, coming to results, overall we had to approach 127 patients to recruit 60 patients, so 20 each into each of the three arms. The acceptability rates were 58% for patients when offered the capsule study, 50% when offered the unsedated transnasal study, and 38% when offered the sedated endoscopy study. Patients tolerated all three procedures well. There were no major or minor complications. With particular reference to the unsedated transnasal endoscopy, 70% of patients tolerated the procedure very well and would prefer that procedure to a sedated endoscopy if it were offered. We detected 3 patients with Barrett's esophagus, all short segments, that is less than 3 centimeters in length, and 8 patients with esophagitis amongst the 60 patients that we were able to screen. This study proves that unsedated endoscopic as well as non-endoscopic techniques may be feasible alternatives to sedated endoscopy. What does this mean for the future? We were fortunate enough to have a larger study funded by the National Institute of Digestive and Kidney Diseases to assess the comparative effectiveness of screening for Barrett's esophagus in the community using both sedated and unsedated transnasal endoscopy. In this larger study, we are approaching 450 subjects in Olmsted County to undergo screening with either sedated or unsedated transnasal endoscopy, and are hoping to show that both techniques are accurate and acceptable. The potential advantages of unsedated techniques, if they are feasible, acceptable, and safe, is that they may be a more cost-effective way of screening for Barrett's in the community. And therefore, we may be able to detect more patients with Barrett's in the community, potentially place them into surveillance, and hopefully improve outcomes of patients with esophageal adenocarcinoma. Thank you.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.